Staying informed about the latest in healthcare, well, it can feel like a monumental task, right?
Oh, absolutely.
So much information coming at you, all these studies, and the big question is always, how does any of this actually translate into better care for patients?
Mhm.
And how can we kind of cut through the noise to understand what really matters?
Yeah.
That's precisely what we're diving deep into today.
We're exploring that vital connection between healthcare research and, what nurses do every single day.
Right.
It's about taking breakthroughs from the lab and integrating them into the practical realities of patient care.
Yeah.
And this isn't just for academics, it's crucial knowledge for anyone, really, who cares about the advancements and, well, the effectiveness of our healthcare system.
Exactly. Our mission today is to really clarify the relationship between something called translational research and evidence-based practice.
Two key concepts.
Definitely.
Yeah.
And we'll also be looking at why sometimes these amazing research findings don't always make it to the bedside, you know?
The implementation gap, it's a big one.
Yeah, it is. And maybe even get a glimpse into how the data in healthcare, both the numbers and like the stories, is analyzed to drive improvements.
Okay.
We're drawing on detailed notes covering nursing informatics, focusing specifically on how research gets translated and how data is understood.
Sounds good. So where should we start?
Okay, so let's get into the core of this.
Let's maybe begin by understanding the difference between translational research and evidence-based practice.
Good idea.
Translational research, at its heart, is really about taking scientific discoveries and turning them into real-world health applications. Imagine it as building a bridge, sort of connecting the research lab to actual patient care.
Right. Building that bridge. And this doesn't happen all at once, does it? Our notes break it down into, what, 4 key phases, T1 through T4?
Exactly. T1 is that crucial first step
Okay.
where a promising discovery in the lab moves into initial studies with humans. Think of it like the very first safety tests.
Ah, okay. Is this actually workable in people?
Precisely. That's where researchers see if an exciting new idea actually has potential within, a living biological system. Then we move to T2.
T2.
Which involves clinical trials. Here, interventions are tested rigorously
Right.
to see if they are truly effective and safe, ultimately leading to the development of practice guidelines.
Those recommendations doctors and nurses use.
Exactly. Those recommendations they use to guide treatment. A key insight here is that a successful T2 trial shows something can work, but usually under pretty controlled conditions.
Gotcha. Controlled conditions. So T3 must be about getting it out there.
Exactly. T3 is where those practice guidelines start to be used in everyday healthcare settings. It's all about implementation in the real world.
Right.
This is where we see if something that worked in a trial actually gets adopted and makes a difference on a larger scale. This phase often reveals the practical challenges.
Yeah, the messy reality.
You got it. And T4 takes an even wider view, evaluating the impact of these implemented practices on the health of entire populations. Are we seeing a real improvement in public health outcomes?
So big picture stuff.
Very big picture. So translational research is this multi-stage, forward-moving process focused on getting innovations out of the lab and into widespread use.
Okay, that makes sense. Now, evidence-based practice, or EBP, it feels like it's coming from a slightly different angle.
It is.
It's more about looking at what we're already doing and asking, how can we do it better using the best available information? Is that fair?
That's a great way to put it. EBP is the conscious effort by a nurse, or any clinician really, to integrate their own clinical expertise with the best research evidence that's out there, while also taking into account the individual preferences and values of the patient.
Patient values.
It's a crucial part, all for making decisions about their care.
And there's a sort of cycle to it, isn't there? Our notes mentioned PI outcome, maybe not in detail, but that cyclical idea.
Exactly. It often starts with a specific question that arises from caring for patients. Maybe something like, for patients with this condition, is treatment A better than treatment B?
A real-world problem.
Exactly. Then it's about finding the research that might answer that question, really looking critically at whether that research is trustworthy.
Appraising it.
Right, appraising it. Then actually applying the findings in practice. And then, importantly, seeing if it led to the outcome you were hoping for. Assessing the results.
So it feeds back into itself.
That cyclical nature is fundamental to EBP. It's driven by the real-world questions that come up daily on clinical practice.
Okay.
Now, if we compare TR and EBP directly, using those features from our notes,
Yeah, let's do that.
we see some key differences in where they start. Translational research, like we said, typically begins with a scientific discovery in a lab.
The bench.
Right. Whereas EBP often starts with a question a nurse or doctor has while caring for a patient
The bedside?
and looks to existing published research and the opinions of experts for answers.
Okay, so different starting points, origin of knowledge, scientific versus clinical. What about what they're trying to achieve? Their purpose.
The main goal of translational research is to take those initial scientific breakthroughs and apply them in a healthcare context, often leading to new treatments, technologies, or even changes in healthcare policy. Innovation, really.
Right, driving innovation. And EBP.
EBP, on the other hand, aims to improve the quality and effectiveness of the care that's already being provided
Okay.
by incorporating the most up-to-date and reliable evidence. It's more about optimizing current practice.
Okay. And how about the process itself? TR has those distinct T1 to T4 phases we discussed,
Yeah, that multi-phase journey.
including the rigorous testing in clinical trials. EBP feels more like a targeted, question-driven approach to finding and using information that's already out there.
Exactly. It's more cyclical, like we mentioned. You ask, find, appraise, apply, assess.
Which leads to different kinds of immediate results or outcomes.
Yes. Translational research might result in, say, a completely new medication becoming available or a national screening guideline being updated, a big shift.
Okay.
EBP is more likely to lead to the adoption of specific best practice guidelines within a particular hospital or clinic for managing, say, wound care or preventing falls, more localized improvements.
Got it. So when we think about the scope, TR seems broader.
Right.
Bench to bedside, even to population health.
Definitely broader. It spans that whole continuum. EBP is maybe narrower, more focused on the immediate decisions and actions happening at the bedside and how existing research can inform those specific actions. Bedside to practice, perhaps?
Okay.
Precisely. Both are absolutely vital for advancing healthcare, but they operate on different scales and with different primary objectives.
But both aiming for better patient outcomes, ultimately.
Absolutely. The key insight is that while their approaches differ, both translational research and evidence-based practice ultimately share the same overarching goal, to improve the health and well-being of patients.
That makes perfect sense. So we have this research being conducted, brilliant ideas potentially, and we have this concept of using evidence to guide how we care for people. But as we hinted, it's not always a simple path from the lab or the research paper to what a nurse actually does when looking after a patient.
Far from it.
So what are the major obstacles? What gets in the way?
That's a really important question, and our notes laid out quite a few. We know research is essential for progress, but actually implementing it widely faces several significant challenges.
Like what?
Well, one of the most common and maybe most relatable is simply a lack of time for nurses.
Yeah, I can imagine.
Their schedules are often incredibly demanding, leaving very little opportunity to actively seek out, critically evaluate, and then figure out how to implement new research findings.
Right.
Think of a nurse working a 12-hour shift, constantly on the go, finding an extra hour to dig into research papers. It's a huge ask.
That's completely understandable. When you're constantly responding to immediate patient needs, delving into the latest studies probably isn't top of mind.
Not usually, no. What other hurdles are there?
Well, the notes mention limited access to the evidence itself.
Ah, yes, that's another major barrier. Many high-quality peer-reviewed research articles are behind paywalls.
Ugh, paywalls.
Exactly. And not all nurses or even institutions have easy access to comprehensive databases, or maybe they lack the skills to effectively navigate these research platforms.
So even if they had the time, finding the info might be tough.
It's like trying to find a crucial piece of information that's locked away, or you don't have the right map to find it.
That issue of paywalls always feels like such a fundamental obstacle to getting vital information to the people who could really use it. Drives me nuts.
Me too. Absolutely. Then there's the natural human tendency, resistance to change.
The we've always done it this way factor.
Precisely. Healthcare, like any established field, has its routines and ways of doing things, and there can be a reluctance, sometimes unconscious, to adopt new practices, even when strong evidence supports them.
People find comfort in familiarity, right?
They really do. That comfort zone can be a powerful force.
And I can imagine that if nurses haven't had specific training in how to critically evaluate research, that could also make them less likely to adopt new findings, even if they found them.
That's another key roadblock identified in the notes: inadequate training. Lack of skills in how to appraise and apply research findings.
Yeah.
Nurses need to feel confident in their ability to understand the methods used in a study judge whether the evidence is relevant and reliable for their specific patients.
It's not just reading the conclusion.
Definitely not. It's about understanding how the researchers got there, the methodology, the stats.
Exactly. It's not just about reading the paper. It's about being able to really dissect it and understand its strengths and weaknesses. Critical appraisal skills.
Critical appraisal, yes. And then we have organizational constraints.
What does that cover? Like the hospital system itself?
Yeah, pretty much. If the leadership within a hospital or clinic doesn't actively encourage and support the use of evidence-based practice.
If it's not a priority.
Exactly. Or if there are no clear policies or, frankly, incentives in place for adopting new research-backed methods, it's much harder for research to be implemented consistently.
So it needs support from the top down.
It really needs to be embedded in the culture, a priority from leadership.
Okay. What about the researchers themselves? Do they play a role in why research might not reach the bedside?
Definitely. Our notes point to poor communication, a disconnect between the researchers who conduct the studies and the nurses and doctors who are providing direct patient care. That can create a significant gap.
How so?
Well, researchers might not always present their findings in a way that is easily understandable or clearly applicable to the day-to-day realities of nursing practice.
Too academic, maybe?
Sometimes, yeah. Or just not framed in a practical way. It's like speaking two different languages sometimes.
That makes sense. It can feel like there are two separate worlds. The academic world of research and the very practical world of caring for patients. Bridging that is key.
Precisely. And that leads to another challenge, the inherent complexity of the research findings themselves.
The statistics again?
Often, yes. Interpreting complex statistical data and understanding all the nuances of research results can be difficult, especially if that's not a regular part of a nurse's daily responsibilities.
Right.
Those statistical analyses, the jargon, it can feel overwhelming if you don't use it regularly.
Those p-values and confidence intervals can certainly feel like a foreign language sometimes. I get that.
They can indeed. Finally, the notes mention technological barriers.
Like the computer systems.
Exactly. If the tools that nurses use every day, like electronic health record systems, EHRs, don't easily integrate with research resources or provide quick access to relevant evidence right there at the point of care, it creates another hurdle.
So if it's hard to quickly look something up while you're with a patient,
you're much less likely to do it. It needs to be seamless.
So it's a really complex picture, isn't it?
Yeah.
Challenges ranging from the individual level, like time and training, to organizational factors, communication issues, and even the technology nurses use.
Exactly. It's multifaceted. Overcoming these barriers requires a coordinated effort from individual nurses, healthcare organizations, researchers, everyone working together.
Yeah.
The key insight here, I think, is that simply producing good research isn't enough. We need to actively work to bridge that gap between discovery and practice.
Okay, so we know researchers are generating all this data, all this potential evidence, and we've just discussed why it doesn't always make its way smoothly into practice.
Right.
But how do researchers actually make sense of all this information in the first place? Let's talk about how they decode the data. What are the main approaches?
This is a fascinating aspect. In healthcare research, there are broadly two main ways to analyze information: quantitative and qualitative.
Quantitative and qualitative. Okay.
Quantitative data deals with numbers, things you can count or measure. Think of it as the objective, measurable aspects.
So things like blood pressure readings?
Yep.
Or the number of patients who recovered using a certain treatment? Or scores on a standardized questionnaire, maybe?
Exactly. All good examples. This type of data can come from surveys using rating scales, direct measurements like blood pressure or lab values, or information pulled from electronic health records.
Okay. So what do they do with these numbers?
Well, the first steps in analyzing quantitative data often involve data cleaning.
Cleaning?
Yeah, identifying and correcting any errors or missing information. You need clean data to get reliable results.
Makes sense.
And coding, which in this context means assigning numerical values to different responses or categories.
Like on a survey.
Right. For instance, on a satisfaction survey, very satisfied might be coded as a 5, satisfied as 4, and so on, down to very dissatisfied as a 1.
Got it.
This allows for statistical analysis.
So you're essentially turning all the different pieces of information into numbers that can then be crunched statistically.
Yeah.
What kinds of analysis techniques are used with this numerical data?
There are several key techniques. First, you have descriptive statistics.
Descriptive, like describing the data.
Exactly. Things like calculating the mean, the median, the middle value if you line them all up, and the standard deviation.
Which tells you how spread out the numbers are.
Precisely. It tells you how much individual data points vary from the average. These help to give a basic summary of the data. Who was in the study, what were their general characteristics, etc.
Okay, the basics, then what?
Then there are inferential statistics.
Inferential, making inferences, drawing conclusions.
You got it. These are used to draw conclusions and identify relationships within the data and maybe generalize to a larger population.
Okay, like what techniques?
Techniques like t-tests, which are often used to compare the averages of two groups.
Like a treatment group versus a control group.
Exactly. Or ANOVA analysis of variance, which lets you compare the averages of more than two groups to see if there's a significant difference somewhere among them.
Okay.
And things like regression analysis, which help see if one variable can predict another, like can age predict recovery time?
Ah, okay. Looking for relationships.
Right. Essentially, these inferential methods help researchers determine if the patterns they observe are statistically meaningful and not just due to random chance.
And I know there are specific software programs that help researchers manage and analyze all these numbers, right? It's not usually done by hand anymore.
Oh, definitely not for large data sets. Tools like SPSS, SAS-R, which is very popular now, and even spreadsheet programs like Excel are commonly used to handle and analyze quantitative data.
Okay, that gives us a good picture of the world of numbers and research. But obviously, not everything in healthcare can be easily measured or counted, right?
Absolutely not.
What about people's experiences, their feelings, their individual perspectives, the why behind the numbers sometimes?
That's where qualitative data comes in, a different but equally important piece of the puzzle.
A lot of cave. Okay.
This type of data is narrative, non-numerical. It's often gathered through methods like in-depth interviews.
Talking one-on-one.
Yep. Or focus groups, where you talk to a small group of people together to get different perspectives interacting. Or even open-ended questions on surveys that allow people to describe their experiences in their own words, not just pick a number.
Right. So how do you analyze words and stories?
Good question. The initial steps often involve transcription.
Typing out the recordings.
Exactly. Typing out the audio recordings of interviews or focus groups into text. And then coding. But coding here is different from quantitative coding.
How so?
Here, it's about reading through the text and identifying recurring themes, key ideas, concepts, or patterns within the words themselves. You're looking for meaning in the narrative.
So instead of assigning a numerical value, you're looking for common threads or repeated concepts in what people are saying or writing. Like, difficulty scheduling appointments might be a code.
Precisely. That's a perfect example. Key analysis techniques for qualitative data include thematic analysis.
Thematic. Finding themes.
Exactly, where researchers group the data into meaningful categories or themes that emerge from the text, like your example, or maybe a theme like fear of side effects in interviews about a new medication.
Okay.
There's also content analysis, which can be a bit more systematic, sometimes involving counting how often specific words or concepts appear in the text to identify emphasis.
Right.
And narrative analysis, which focuses more on understanding the individual stories people tell and the broader context behind the data that's being shared, really digging into the story itself.
That sounds like it can provide a much deeper and richer understanding of the why behind the numbers we might see in quantitative data.
It absolutely can. It adds that layer of human experience and context.
And are there specific software tools that researchers use for qualitative analysis as well? I imagine sifting through pages of text can be daunting.
Yes, definitely. There are specialized programs like NVivo, Atlas.ei, and MXQDA that help researchers manage, organize, code, and analyze large amounts of qualitative data much more efficiently. They help find patterns in the text.
Okay, so it sounds like both quantitative, the numbers, and qualitative, the narratives, offer really valuable insights, just in different ways.
That's the key takeaway. One focusing on measurement and statistics, the other on experiences, meanings, and context.
Is there a way for researchers to use both, like combine them?
Absolutely, and that's becoming increasingly common and valued. It's called the mixed methods approach.
Mixed methods.
It combines both quantitative and qualitative data collection and analysis within a single study.
What's the benefit of doing that?
Well, it can provide a much more comprehensive, sort of holistic and nuanced understanding of a research question.
How so?
The numbers, the quantitative data, can show you the trends, the what, and the scale of an issue,
Okay.
while the qualitative data can provide the rich context, the why, and explain the underlying reasons and experiences behind those numbers.
Ah, like the numbers show that satisfaction is low and the interviews explain why it's low.
Exactly. It often leads to the most powerful and insightful findings because you get both the breadth and the depth.
So, okay, let's try and bring this all together. We've explored how translational research, that TR, aims to take scientific discoveries and put them into practical use in healthcare,
Right, the bench-to-bedside journey.
and how evidence-based practice, EBP, focuses more on using the best available research right now to improve the care nurses provide every day.
Using current evidence smartly.
Mm-hmm.
We've also looked at those significant challenges, the barriers, lack of time, access issues, resistance to change, training gaps, organizational stuff that can prevent research from actually reaching the patients who could benefit.
Yeah, the crucial implementation piece. And finally, we've delved into the fundamental ways that researchers analyze data, both the numerical, quantitative stuff,
Means, medians, t-tests.
and the narrative, qualitative information,
Themes, stories, context.
to generate the evidence that underpins advancements in healthcare. And sometimes mixing both.
That's an excellent summary of our deep dive. Understanding these core concepts, TR, EBP, the barriers, the data analysis approaches, is incredibly valuable for anyone wanting to really grasp the foundations of how healthcare is continuously improving.
Yeah, and the science behind nursing practice itself.
Absolutely.
So considering these different approaches to research, TR and EBP, and all those hurdles and actually applying them, here's a thought to leave you with. What's one single change that you think would have the biggest impact? The biggest impact on making sure the latest evidence effectively benefits patients most effectively. It's definitely something to think about, isn't it?
It really is. There's no single easy answer there. But ultimately, a deeper understanding of these foundational concepts empowers you, the listener, to be more informed and engaged with the ongoing evolution of healthcare.
Yeah, allowing for a more critical, maybe more insightful perspective on the advancements that are shaping how patients receive care now and in the future.
Well said.